Hello, everyone, and thank you for joining us for today's webinar. Just a couple quick things before we get started. You can use your chat function throughout the webinar to send in your questions, and we'll try to get to those at the end. And for those of you that are attending in the U.S., your certificates should be available on Tuesday due to the holiday by logging into your account. Leon, if you want to go ahead and introduce our speaker, go right ahead.
Thank you, Kim, and welcome everyone. My name is Leon Matoulis. I'm the Head of Medical Research at Medeala. Thanks for joining us today, and welcome back if you participated in our previous seminars, webinars in this series. As a starting point, for us, we're all aware of the impact that the COVID-19 pandemic has had on the way we work and function. And in particular, one thing that's really concerned us and one thing that we've observed is the potential impact that COVID-19 has on breastfeeding at a global scale and the use of human milk for that matter. Indeed, we've seen a lot of varied reports in either the popular press or even in the scientific literature about the use of human milk and breastfeeding. And even though one thing we have noticed is that global organisations like the UN and the WHO and UNICEF, they've all been very clear about how mothers can breastfeed during this pandemic. But despite the discrepancies between the popular press and the UN and these other organisations, there's still a lot of uncertainty out there. And so what we thought to do was to try and bring some of the world's leading researchers together through a series of webinars to try and cut through that misinformation and provide a little bit of clarity for researchers and healthcare professionals around the world, in particular in relationship to the use of human milk and breastfeeding. So to date, we've been very fortunate. So far, we've heard from Professor Diane Spatz, who provided us with an overall starting point and a bigger picture of COVID-19 and human milk. And then we moved to Professor Lars Oder, who really gave us some clarity about the investigating SARS-CoV-2 in human milk. And today we're very fortunate to be able to bring you Professor Jae Kim. Professor Kim is a faculty member and director of the Division of Neonatology at Cincinnati Children's, and he brings a tremendous body of knowledge when it comes to the use of human milk in the NICU, and has done a lot of research over the years looking at infant nutrition, and in particular relating that back to human lactation and the use of human milk. So what I would like to do is now to welcome Jae and to hand the microphone over to Jae. Thanks very much.
Thanks, Leon and Kim and the education team. It's great to be at this venue and to kind of continue the series that you've prepared for the outside audience. I think it's unprecedented times, and I really hope that I can contribute a perspective of some of the things that we have been going through locally from a clinical point of view, which I think has been very dynamic in this pandemic, and I think it's going to continue to be dynamic as we move forward, particularly in the U.S. And I'm going to try to highlight some things, and hopefully it's not duplicative to the previous sessions if some of you are coming from those sessions as well. But I did want to kind of give you perspective of where the science is and how that intersects with practices around use of milk in the NICU and how it all kind of interacts ultimately to the performance of us being able to deliver the best nutrition, and how we've had guidance from multiple sources and how that's influenced our practices and may in fact continue to be changing as we go forward. And at the end, maybe highlight how our roles as healthcare providers in the field really need to take a look at advocacy around human milk use and breastfeeding since these times of crisis often shake the trees a little bit about how we do practice. So I'll hopefully cover a bit of the science, and a bit of the how it interacts with our current models of providing milk in the NICU and in the newborn space, and then talk a little bit of how we may have some perspective of this situation against what we were used to doing. So many of us are trying to get a framework of how coronavirus, SARS-2 or COVID-19 is working. Exactly what's the science behind it in terms of its infectivity and its ability to harm, and particularly ability to kill people. And I think it's important to put these characteristics into a framework, because they directly impact how we interpret our guidance in the hospitals, whether it comes to the pregnant mother all the way through to the care of the newborn in hospital. So we understand now that there's a significant proportion of spread of this virus through airborne and droplet means. The data that suggests that there may be particles detected in stool does not seem to be a major thing. And what's become very good and clear from more specific data about spread is that actions beyond just coughing, singing, loud speaking, those types of things have been really clear mechanisms of transmission. So the idea of using PPE, masks particularly, is a really important measure, and it's something that we've been kind of had early on significant shortages, and it really drove home some of the critical elements of like what kind of mask should we be wearing when a suspect mom comes in, when we have a baby on a resuscitation table and there may be aerosolization of particles, and how do we manage that situation. So knowing how the virus spread has direct impact on how we practice, and shortages or concerns about resources also played into effect. The other model that has continued to change, has become a lot clearer now than it was at the beginning, is the idea of how the disease natural history occurs. So from the time of exposure, once that transmission has occurred, we do recognize that symptoms or the positivity of that individual occurs on average somewhere around 5 days. And just prior to that, there's a level of infectivity that we recognize, and that is identifying someone who is not just asymptomatic, but pre-symptomatic in cases. So they may have no symptoms, but still be shedding virus and still be infectious. And then we recognize that some have no symptoms and may be asymptomatic throughout the whole course, and these are typically younger people that do that. And the PCR tests that have been done that detect virus particles have clearly shown that we have shedding that occurs far beyond the infective period, far beyond the symptomatic period, and that adds to some of the confusion when we're using test-based strategies to identify who's safe and who's not, particularly when we're trying to figure out infectious nature. So it's a good framework to go with, because knowing how the disease works is going to impact how we practice. Now, we have gone through significant flattening of the curve strategies by sheltering in place and also significantly reducing workforce and sort of density of people, so social distancing in the work environment. And this has had multiple impacts along the spectrum. And I hope to kind of cover the areas which really how they kind of is a continuum from the delivery of the mother all the way to the infant going home, and identify some of the challenges that we might face in trying to determine what's best to do and how it might impact on actual milk availability or milk production and breastfeeding. So to start, I think we've been very reassured that up until now, we have not been participating as neonatologists or neonatal caregivers in a space that is highest risk. In other words, pregnant mothers, young mothers, and newborn babies are not a determined higher risk group in general. So in particular with pregnant mothers, we understand that they often are asymptomatic, and data has been shown in New York and other hot zones when they've looked that positivity can be just incidental. And we've seen this here in Cincinnati and in Ohio, where a significant number of positive mothers are simply asymptomatic and may have had turned positive many weeks before, so they may even be not infectious. But we also know the counter to that is that mothers can get sick, and some can get very sick and go into the ICU, and some can rarely die. So it's not totally inconsequential. And a lot of times we're trying to make a risk assessment at the time, and this happened when the surge occurred, when we're trying to look at what's available in terms of equipment, resources, testing availability, the accuracy of the test, and also the turnaround of the test results, because that may impact on how we choose to make guidelines or choose to make decisions. The other question that's been out there and still is reassuring is this idea of transplacental vertical transmission from mom to fetus or to baby. And we think that if there's some reports that are out there, but it's most likely to be exceedingly rare for that to occur, and that most of the time when we're looking at consequences to the fetus, we're looking at situations like other complications with mother's health, pre-existing conditions or conditions that occurred during her actual pregnancy or delivery that lead to complications to the fetus. So the scenario at birth was a really complicated area when COVID-19 first hit, trying to figure out where are the risk points when mother is delivering either vaginally or delivering by C-section. There were nuances to this as we understood the virus more and more, that a mother who's delivering vaginally may be pushing hard and therefore breathing really hard, so putting a mask on her may be somewhat protective, but we know that there may be aerosolization despite that. Oftentimes the mask would fall off, and the ability to have physical distancing from the mother would be obviously very difficult for a lot of the providers. We had created separation of space, either taking the baby outside of the delivery area to a separate room, or trying to do it with at least 6 feet distance from the mother to try to prevent aerosolization risk. And then the risk early on, we had contemplated this risk of particles that are found in the stool, and whether those viral particles could be infectious. And at the time, since the anus is very close to the vagina, that may be at vaginal birth, there may be contamination risk on the surface, and therefore trying to be really cautious around that. There was a lot of concern in that measure. I think we've been, with good PPE use at the time of delivery, a lot of those concerns have been abated. With cesarean section, obviously, we've got a cleaner environment and not a huffing mother situation, but we still have risk with the proximity to the mother and also the chance that there's some aerosolization close up, even despite masking. But perhaps maybe there's a slightly lower risk in a symptomatic mother's situation. And then the situation at the resuscitation, I think we've gone through several iterations identifying how risky that situation could be. In a routine delivery, just drying and stimulating probably is not a huge thing, since the actual tidal volume and spread of anything aerosolized is probably, one, minimal in a child, and two, in a newborn, probably has not been infected in the respiratory system, and so therefore would not be spreading that way. So it's mostly droplet contact that might have been at most the risk factors. So a lot of, I think, reduction in our concern in that that point. We've had challenges trying to separate out the asymptomatic mother and the pre-symptomatic mother, especially in the early time when we were faced with inability to have appropriate equipment and appropriate testing results. Things have gotten significantly better around the country and in our area, but even more recently, we've seen situations where we've gone away from universal testing to situations of more targeted because of limitations in testing. And this is important to consider as more surging is happening across the country. And then the one big question that people had was around, can newborns acquire the virus at the time of birth, shortly after birth? And there's no question now that event occurs, and that event can occur even within the first 24 hours. And it's often very difficult to separate out whether that's really true vertical transmission or just transmission shortly after birth, because of the environment, either if it was a home birth situation or in different settings. But suffice to say that the newborns that do contract it are, by and large, very minimally affected, with very few cases of significant illness. And then for older children, the main ability to pick it up is from infected individuals, either mother or at home. The global data had suggested that there may be a slightly higher uptick in the pediatric population for those less than 1 year of age, but it's not clear whether that really falls into the 1 or 2 month old period, because the data is so minimal. And then children had been considered pretty much a low risk group, but one of the things that adds to the whole nuance of trying to understand risk is this inflammatory condition that does affect some of these children. And this is a condition called multi-system inflammatory syndrome in children, or MIS-C. And it's clear that this is a post-infectious inflammatory condition, not different, but often very similar in sort of characteristics to Kawasaki's disease. And that's important to recognize because this can be quite multi-organ in involvement, and unlike Kawasaki's disease, there have been I think a little bit more of an uptick in mortality. So there is some concern that this is definitely a significant event that can occur rarely in some kids. What's less clear is exactly what makes someone susceptible to this, and also for our population, I haven't seen anything that really identifies infants who are exposed early, infected, and then ultimately develop this syndrome. Most of the kids have been much older in the pre-adolescent age group on average. So, but it is something that's now made it concerning overall. And we have recommendations, as Leon actually mentioned at the beginning, that in our response to the virus coming out, that there was pretty good resounding sort of recommendations worldwide to sort of say that we try our best to preserve breastfeeding, whether it was the WHO to try to maintain mother and infant together. In America, and with the AAP and the American Academy of Pediatrics and CDC, there was initially probably a little less staunch approach to this, and the recommendation is really to try to provide more shared discussion around the practice of breastfeeding. And particularly, I'll talk about the AAP guidance. When this first hit with COVID, there was initial concern about having mom and baby together, and this later changed with much more support of direct ability to have direct breastfeeding with under discussion with parents. But I think the overall American Academy pediatrics approach has been nicely detailed to give guidance for neonatal providers from the beginning to the end of hospitalization. So these include, and they're listed in that summary on the web page, but they included stuff that happened at the delivery, practices with delayed cord clamping, and then we'll talk a little bit more about the rooming in and guidance around that and breastfeeding, but also introducing some early bathing, which is a little bit counter to many people's practices, and then guidance around discharge. So I want to cover the normal newborn situation versus the NICU situation because I think they're unique in what we had to deal with and also perhaps maybe the impact that these might have overall on breastfeeding and human milk performance. And that is, depending on the circumstances you had physically in a hospital, the ability to separate mother and baby with a positive mother may be limited by what you had available in terms of space. So the guidance that was out there to try to allow parents to make a decision whether mother and baby stayed together on the one hand or be separated, and if they're separated, separation occurs in a different model, either in a similar room and separated by distance and appropriate equipment, or separated totally by separate rooms next to each other. And we saw both of these scenarios happen in our system depending on the unit and the circumstances of the parents. But a lot of angst had gone into trying to decipher what would be the right conditions for this. And I'll come back to this in a moment. And then caring for the NICU baby was different because clearly the mother doesn't accompany the baby at that time. The baby comes down to the NICU, and the baby initially, a fresh-born baby is not symptomatic at that time, but may be a contact of either a person under investigation, a PUI, or someone who's positive. And so we would have to keep them, if they were not in a single room type of unit, to find a single room, and depending on whether they had symptoms develop, put them into a negative pressure. But I think even in the beginning we were putting babies into negative pressure rooms just to be safe. But this configuration obviously introduces some challenges when we start to look at the impact that having multiple at-risk babies has on the unit in terms of the geography, in terms of impact on staffing. And we'll talk more about visitation as it impacts how to manage infants that are either with symptoms, but most of the time just having contact with someone who has symptoms. So a large stressor to the system has been around visitation, and there's been a number of discussions and polling around the country to try to figure out what other people were doing and what was reasonable. At the beginning, we actually ended up having a lot of restriction in terms of visitation, with almost to the point where we completely separated out exposure infants and from visitors, such that we had very low visitor numbers from the start, and a relaxation of those visitor numbers that now allow for 1 to 2 in both cases, whether it's the mother-baby unit or the NICU. And even in the NICU, we still have situations where visitation may be just limited to one person, and that generally is either the mother or the father. So this area of policy, I think, was a big stressor, and it'll come back to play when we talk about how it might impact milk production. And then guidance as to once we have a mother who is positive or still suspect, and how to guide them to return, whether it's symptom-based or test-based. The CDC and the AAP both have guidance that leaned on this, and the challenge with this has been obviously the time that it takes to clear a mother and the time that it takes when you use a test-based strategy. So I'll mention with the test-based strategy, the real challenge there is that test-based strategies is flawed to some extent because mothers who, as I've shown you at the very beginning, who are positive, who may have started to resolve in symptoms, may actually remain positive with at least with the PCR, RT-PCR testing after many days to weeks after their symptom period. So in general, that's probably a poor way to try to clear a mother in terms of getting them able to come back and visit. And then with respect to infants, that's a little bit more straightforward. But this symptom-based strategy generally has been a period where we've had to separate out mom from the hospital initially, and then have to wait till they're cleared. So many places have moved from being very dogmatic about one approach versus the other, whether it was separation or co-localization. And we've gone with the model that's been used by many people, which is a shared decision-making model. So we actually go through the different pathways with the parents and inform them about the value of the different ones and what we know of the virus and the pros and cons of this. But clearly the challenges that occur with a separation model is the physical separation of mom and baby for large stretches of time, even if they are within even the physical distance within a room, but also having a challenge with being able to have stimulus for milk production, and of course being able to have enough of that exposure time for the mom to produce milk. But we have not moved from, I think most people are still in this shared decision-making situation because of a lot of the context that changes from in different places and with different parents. And then I think the other area of concern was around discharge and trying to determine how to clear, especially with a newborn baby that's healthy. Oftentimes testing was very, very delayed in getting results, and so having a suspect infant often put them on watch and under these separation protocols to really put a rift between mom and baby and the natural breastfeeding attempts. And then sending a baby home with precautions, and I'll talk about this some more, but the context of what happens at home is very different from what happens in the hospital in terms of guidance, and oftentimes they can be very difficult to resolve from the parent's perspective. Why are we being so cautious in hospital when we're going to go home and actually be together at that point? So back to the normal newborn situation, I think what we've observed is the separation of mom and baby has introduced a lot of challenges, both from a staffing point of view, but also that physical separation of mom and baby, the introduction of a lot of different PPE in order to try to keep the baby safe from getting infected from a positive mother. And the question in the normal newborn space is how much does that impact on breastfeeding? Our observation so far has been reasonably positive, same levels, if not better. And one of the considerations that comes into play in this space is the idea that in normal newborn postpartum space, we often have a lot of people coming and going, visitors, and commotion, which may affect mother's ability to really bond and be with their baby. So there may be some surprising positive effects of kind of really controlling the postpartum experience and putting in those guidelines to be able to make sure that mom is able to have enough time with baby, being able to breastfeed and to do that under a controlled situation. What's different from that is in the NICU, we clearly have separation of mom and baby, and that makes it very difficult to be able to have provision of milk. At the beginning, there was some concern of whether even in asymptomatic infants that were just contacts, whether they would be housed in the NICU, and that initially would have been really, really difficult. Most of the time we've been able to, and most others have been able to have the baby still stay up in the postpartum area. But for those that are, either because they're preterm or have other concerns, mother is sick and we have the separation, then we obviously have imposed significantly greater challenges to the ability to provide milk. Obvious one is that if the mom is very, very sick, then she's not going to be able to provide milk. Other effects, though, are the impact on the NICU, having one or more babies that require that extra precautions, whether it is the introduction of putting them in a negative pressure room because of concern of symptoms, and changes in the PPE use. So when it was restricted and we had shortages, then it became very difficult to have a lot of people go in and out, and the visitation policies, as I mentioned, had huge impact on the NICU because of either going down to 0 visitors to even 1 or 2. We've reduced the contact points of mom and baby, and now when we're have infants in the NICU that have only one or the other visiting, we even in a steady state we're separating out mom and baby from having normal interactions, and to what extent that impacts milk production is not entirely clear, but clearly we've seen an impact in milk production because of all the above mentioned situations. So I think the challenge that this has opened up for all of us is looking at the framework upon, and this is complex, is how do we end up getting milk in the NICU? How do we get breastfeeding to occur in the normal newborn space? And what are all the pieces that we have, the physical space, the human support of milk production or breastfeeding, and also the really paying attention to the contact time of mom and baby, which we had significant separation in both scenarios, and especially at the very beginning. And then how can we provide ongoing equipment support, say in the NICU, and then guidance when they go home. And especially in the NICU, since it's a much longer hospitalization stay, we have more chance for impacting mother's milk production in that space. And so I think it's challenged us overall to question, like, are we, how does a pandemic or a virus like COVID impact our ability to have moms produce adequate amount of milk? So what's been, and maybe you might have heard of some of this before in the other sessions, but one of the big concerns was detecting early on whether we had coronavirus in milk itself. The short answer to this is that we can detect fragments of coronavirus, but in fact we do not have strong evidence to support that these are active viral particles in the milk, which is very reassuring. Moreover, even if there were active virus in the milk and these were ingested, ingestion through the GI tract is generally not considered a route of entry. So it's more about the contact of the virus and then contact of the virus to the respiratory system, whether it's the eyes or the nose or the mouth, and then inhaled into the respiratory tract would be the route that'd be more concerning. And then the other aspect that really comes to play is the contamination potentially of the container itself, mostly from the outside if mom is positive. So there's been some controversy about how stringent we should be in terms of cleaning the outside of the bottle, and this has impact on the handling of bottles that come from home, that a positive mom may bring into the hospital, or the transfer of the milk into situations like donor human milk banking. So the idea of how should we maintain the cleanliness of the outside of the bottle. And there's been some questions about how to what level we use chemical products in decontaminating the outside of the bottle. And my perspective on this, looking at the literature, is that clearly there's recommendations that come out that both support obviously good cleaning of the outside with soap and water, and in some cases, if you have the availability of mild bleach solutions as being probably the strongest version of a chemical agent, there have been recommendations to consider that. I think one of the things to consider when you think about the virus itself is to look at the physical chemical properties of virus, especially the surface and the lipid nature of it, that there's quite a bit of evidence to suggest that even simple soap, so not just water, because water is not enough to really harm the virus, may agitate off the outside of the container, but it will definitely, through the dual surfactant property of a hydrophilic and a hydrophobic end, can disrupt the surface of the virus and disintegrate it. That this may be a happy medium point in terms of being able to clean outside of any container. I mean, this is what we are recommended to clean off our hands by using good agitation and use of soap and water to clean and to eliminate it and as much viral particles off our hands. So I think from a physical chemical perspective, soap may actually be a mid-ground solution where if accidentally soap got into and got contaminated into the milk, that we would not be that worried. That being said, if you use mild bleach also is very fragile, and it will sort of break up over time, and probably in and of itself is not too harmful if it were to accidentally get contaminated into the milk. And so I know that there's been a lot of discussion and letters in the literature regarding this. Most are pretty solid in terms of how we recommend moms to pump for and use equipment to try to avoid the contamination if mom is positive. So that involves having masks, which we know now after initial controversy of the value of the mask, and masks do in fact prevent viral particles from aerosolizing and landing on surfaces. And then again, the hand washing and cleaning all the different parts of the equipment effectively would be important. So I think the concept of soap and water is still very valid for that. And because of concern around the virus and whether it was in the milk or not, the concern for safety in the human milk banking industry came about. And we have plenty of data to suggest that the prior practices and guidelines that have been in place and the prior concerns of other viral particles like HIV, even other respiratory virus, SARS and MERS and other coronavirus family viruses, that the pasteurization through Holder heating has been very effective. The only real pathogen we know that kind of survives Holder pasteurization is these bacterial spores that are heat resistant, and there are mitigation processes that milk banks use to make sure that that's low, and they test for it. And anecdotally, there's data suggests that when COVID hit, that milk volumes through donation were limited because moms weren't able to travel or to have access, and also the safety factor. It is less clear in the U.S. whether this is a clear and present problem, and I think more time we'll have to see. Some have reported some volumes drops and others have not. So I wanted to close by kind of looking at some of the aspects I think has been challenging in this whole experience. One is the things that are not said. and that is, concern about the virus that we don't know much about, and fear of the unknown, and then the almost immediate sort of interpretation that bodily fluids, again, are unsafe. The prior issues that we faced with human milk having an ick factor, it's coming from someone, it's biologic. The strong fear of the contagion of the virus, and being so strong that we're willing to separate mother and baby. And it really speaks to, and now that we've heard a lot about implicit bias, but the implicit bias that occurs when it's very easy to separate out, or the medical profession tends to jump to, we've got to sort of control the elements and separate mom and baby. And the hospital environment is a very different environment from home. And I think there's a juxtaposition of mom and baby in the hospital and how we control those elements to how that occurs at home. And I think we sometimes forget that the very next day or the very next hour when a baby leaves a hospital, they're entering a very different environment. And then the flip side, of course, is that the hospital has other patients to take care of and to protect, has healthcare workers to protect. And so rules have to be different, but we also have to understand that that the context from the baby and the parent side may be very different. The other aspect that I think I witness and I keep witnessing is that because we put a huge magnifying glass on the problem of coronavirus, we have now really dropped our tolerance level for any degree of risk. And the truth is we live in an environment where we have microbes everywhere. And when we do medicine before COVID-19, we had always accepted that there's some risk, whether it's from RSV or influenza or other pathogens in the environment, that we had not completely expected zero risk. The challenge, however, is that we don't know a lot about, we're learning a lot, but we still don't know enough about COVID-19. And so with that incomplete data, there's still hesitancy and fear around that. So the questions we should ask ourselves is, what amount of risk are we willing to take? How do we balance that to societal norms and getting back to work? People have worried about the economy, but also, what are the balancing, or rather, what are the risks that we're not willing to tolerate? How many infants who get MIS-C, the inflammatory condition, how much death are we willing to tolerate and in our patient population? And what are the balancing measures when we think about the unintended consequences when we make decisions and don't pay attention to other things outside, and in this case, sort of the effect on feeding and provision of milk. And so if we were to sort of take a big picture view, we know our patient population, mother and baby, are not in the high risk. They're in the low risk category for the most part. And we know that most of the time, the vast majority of the time, mom and baby, even if baby gets contracted the virus from the mother or from others, is going to do well. And that our infants are not a source of spread typically of the virus, even if they are infected. So the risk to the mother is low. The risk to the infant, we look at, even if they acquired it early in the first few days, when they acquired it 2 weeks later when they go home, we're still looking at very, very low risk. So one perspective is to say, if we knew, with greater precision or accuracy of the risk, would we change how we manage mother and baby? So one of the concerns is how sacred is this mother-baby dyad in our healthcare systems, when mother and baby really biologically need to be together, and that the challenges of keeping them together when fear comes in and when the medical system gets shaken up like with COVID, that we have a potential risk of separating the mother-baby diet, and to think about like what makes us go to that level. And some of the unintended consequences besides this concept of potentially really failing in lactation, and then of course the downstream effect of not having enough milk, not having enough breastfeeding for a baby, and then the health consequences to the baby. But I worry about the maternal psychological health consequences, and then obviously the detachment effects of having mom and baby separated for long periods of time early on, which is less easy to quantify. So in this time of uncertainty and obviously danger, what are we advocating for? Where should we stand up against? And particularly as I'd like to be able to say this was history. This happened, and we learn our lessons. But at least in the U.S., we have it's really not even a second wave. It's a continuance of the first wave, a resurgence that's happening across. So the threat to us is that we're probably going to have more positive mothers. We're probably going to have impact on our staffing. We're probably going to have, I think, challenges in all our resources. And then what does that do to our donor milk supply? And how are we going to re-look at visitation practice? Are we going to recoil back overall? So I'll stop there and just sort of summarize. Hopefully I've impressed upon you that we're in a terrible situation with a very contagious virus, and that we know more now, but there's still much more that we should know, that the pandemic has put enough stresses on our system for us to really start to understand that complex processes like the ability to provide support for moms to breastfeed or to provide milk are complicated and very easy to disrupt. And we may be seeing some lessons learned, positive and negative, that in the newborn space, perhaps that postpartum experience of having lots of people and visitors and the chaos may be providing a really controlled environment for a lot of moms, and giving that special time for mom and baby to be together may be a secret to providing much more milk and establishing breastfeeding better than what we had previously allowed. And then for the NICU, the threat of really challenging the ability to provide adequate milk, and also the threat to donor milk provision clearly are things that we need to be considering. And I think I've heard this many times in arbitrating whether moms are they considered a visitor, and really they really should be considered part of the mother-baby diet. So maybe others have commented whether they should be essential caregivers. I just think the mother-baby diet is something we should identify and preserve. So I'm going to stop there, and Leon, I think you're going to be moderating some questions. I'm happy to answer them.
Yeah, Jay, thanks very much for that. We do have a couple of questions coming through. One in particular, I suppose, one clarification from the start of your talk. If you could just provide a few words to explain the difference between shedding, viral shedding, and infectivity in the instance of COVID-19, or in general.
Yeah, so I think the difference is that when you use a test with RT-PCR, that you are detecting the genetic material. So that can allow you to detect a live virus or even a dead fragmented virus. And so the detection of the virus by RT-PCR does not actually give you infectivity. Infectivity is when there's ability to have either you can culture the virus, or you have evidence that what you detected translated into symptoms and have clinical data to suggest that. And we know that post-infection, that period of time is somewhere around 9 or 10 days. And that's why we have to wait at least that 10-day period after development of symptoms to clear anyone, even if they're positive, because a lot of people are positive weeks later and they're probably not infectious anymore.
Okay, thank you. Another question is relating to, I suppose, actual practice in a way, and you mentioned the challenges of what happens when in your situation. Do you have, for example, either written procedures, or is there a a convention in a way that really does track, how to properly, transport and transfer the milk from a COVID-19 positive mum who's inpatient to her baby in the NICU. Like, what would that pathway look like in a real pragmatic and practical context?
So, I mean, we have leaned on our usual practices, because at the beginning I think there was real concern about like what's on the outside of a say a bottle of milk from mom who is positive, who's symptomatic. But I think we've become comfortable knowing that our typical processes are probably pretty good. And so we're not, for instance, separating them into a separate freezer or a separate fridge. You can definitely keep them in the same. I think the most important step that you put into play is ensuring that when you receive the milk that you go through just a simple wipe down. And my recommendation is that you choose between the soap and water version, which I think is as effective as anything else out there, and it's very something that's very easy to do, versus a mild, low level bleach, low concentration bleach cleaning procedure.
Mm-hmm. Okay, thank you. Question: you focused a little bit on risk towards the end there, and you had in your model up front the shared decision-making model. Can you talk us through how that happens in real time, in a way, that shared decision-making model? And we've seen the assessment of risk. How do you have that conversation with a new mum?
Mm-hmm. So I think the concept of shared decision-making is you need to provide information and then also understand the context from the parent's perspective, because those sort of things play together. And I have to say that the shared decision-making model, that process obviously changes over time as we get better informed about the virus. So at the beginning, we had much less information about what was the transmission possibilities, what was how bad the disease could be in a mother and a baby. So we had more tendency to lean toward controlling the decision, to a more shared model where we said we believe, and the current position is that we believe that the risk is very, very low, that even in the worst case that mom and baby both get infected, that we're dealing with a fairly low risk situation. That being said, if parents have concerns, and the concern can even be more contextual, like they have grandparents that are in the house or other people who have health conditions that put them at risk and they're concerned about spreading it at home, need to be factored in. So giving shared decision making really informs the parents and then allows them to look at the two models and say we're happy to support either one, and allow them to ultimately make the decision and give them a little bit more autonomy.
Right. Just switching to the mother who is healthy, who isn't positive and is not under investigation. One of the points you mentioned was that the lack of visitors, for example, provides an opportunity to focus and for bonding and for maybe increased time alone together. How has that impacted your breastfeeding rates at discharge from your maternity wards? And have there been any negative impacts that you've noticed with some of the measures that you talked about? Have they impacted negatively on initiation rates at all?
Yeah, so I think we have seen an early separation between those moms and this is anecdotal, what we're witnessing in the short term that the COVID has happened, and it is separating out those that are in the newborn space and those that are in the NICU, and our interpretation of that, where we're seeing much better breastfeeding rates in the normal newborn in some of our units is that perhaps what people are witnessing is that they're just left alone. Mom and baby are left alone. There isn't this constant onslaught of visitors, and so perhaps that's giving them more time to really let nature happen, which is the natural stimulus to and more bonding, physical bonding of mom and baby, which I think in general we're still not doing as good a job if you really look at the biology of really how close mom and baby ought to be physically. So I think that's one thing. And in the NICU, there's no question when you automatically separate out mother for a period of time, and then you're looking at trying to provide a stream of production of milk, and then when you have visitor numbers that are low, and in some cases having mom and then dad visit on alternate days or struggling with that visitation policy, can have huge impact on numbers, and we've seen that for sure in our NICU population that could be a risk for more for milk provision than breastfeeding because they're often preterm babies.
Right. Another question here in relationship to the strategies that you mentioned. You had the symptom-based and the testing-based, and you were leaning towards the symptom-based from what I understood. When it comes to the testing-based, there's a question here of, do you consider one positive test? How frequently is the testing in those situations, and is that one of the reasons why it's perhaps not the better strategy?
Right. So testing has gone through a whole bunch of phases. So I think the challenge with testing are the following. The one I mentioned already, which is that testing doesn't tell you about infectivity. So you might end up labeling a mom if you test her continuously. You'll just have her positive, and then be able to get stuck restricting her because she's still got positive tests, and she may not be infectious anymore. In fact, some of the moms, and many of the moms that we detect are asymptomatic from the start and probably not shedding any live virus whatsoever. So even at the start, we're probably labeling them incorrectly because they may have been sick 3 weeks ago prior to birth, and we're now preventing her from being able to see their baby, for instance. And so, or putting up restrictions which make it a lot more prohibitive for mom. So the testing, there's other testing that's out there that are antibody-based. Unfortunately, those are not ready for prime time because they're still fraught with, one, it takes time for them to convert, and two, they don't necessarily give us all the data. There may be false positives with them. They also may not be detecting true protection for the host. So having a testing-based strategy, the risk of testing many times is that you're going to prevent mom from being able to visit or be closer to her child.
Right.
Whereas the symptom-based will just be a time clock. So it's still not great because you're either counting from the first test or first symptoms and then counting number of days. But that's at least better than the testing based.
Right. A quick question here in your experience so far. Have you had an experience with a COVID positive mum who was so incapacitated by the illness? Is that something that you have seen, and is there a frequency associated with that?
So there have been several cases described of moms that have been sick enough to undergo ICU admission and then ECMO. We've been fortunate to not had we've had several moms that have been positive. Most of our moms have been asymptomatic or mildly symptomatic.
Right. Okay. We're coming up to the hour. One last question here from all the support mechanisms that you outlined that you now have more of a heightened visibility towards, I suppose, in this situations force you to think more about how to bring this support to mums. So in your facility, have they positively impacted the role or the view of breastfeeding and human lactation, potentially?
I think, this is probably an evolution for all of us, but I think what this has taught us is that every unit and every hospital is different, and that it's really important for each of us to characterize, maybe it's a little mind map or a visual, all the things that ultimately lead you to developing a good amount of mother's milk production or breastfeeding or both, and what are the determinants that in your unit, in your context, lead you to produce that effect. And it's more than just having enough lactation consultants. It's all about the physical space, the staffing, the nurse, who are all the players, and all the different processes that ultimately lead, to the production of milk for pumping and also for breastfeeding support, and being more conscious of that when you're looking at disaster planning, and that's basically what we're going through is trying to identify for each of our units, what ultimately leads to stability of mother's milk production.
Okay.
Thank you, Jae.
Go
sorry,
ahead,
Leanne.
Thank you. No, thank you.
It is top of the hour, as Leanne said. Thank you, Jae, for that presentation. It was wonderful. We did have some other questions come in, and I did save those, so I will send those over to you, Jae, to answer as time permits. I know you're very busy, and we'll get those back out to everyone. Just so everyone knows, as a reminder, the attendees that are on today from the U.S., your certificates should be available for downloading off your account on Tuesday. Due to the holiday, there'll be a slight delay. And our registration for the up-and-coming webinars for July 9th, July 15th, July 21st, and August 19th, registration is available at medilaeducation.com. If you want to look at that website for more information and to register, feel free. And I hope everyone has a great rest of your day. Thank you for joining again. Happy 4th of July as well for those in the U.S.
Thanks, everybody.